This is episode 72 of AA Beyond Belief, the podcast, and I'm your host, John S. In today's episode, I'll be speaking with Dr. Nicole Labor about the neurobiology of addiction. I first learned about Dr. Labor several months ago when a visitor to our site sent me a link to a talk she gave at Kent State. I found her presentation so compelling, and as I became interested in the science of addiction, I returned to it several times. Never dreaming she would actually come on a podcast, I took a chance and sent her an email. Much to my surprise, she agreed. And here we go. My talk with Dr. Labor about the science of addiction. First of all, I want to thank you. I have a couple of messages to pass on to you from a couple of people. There's Kaylee P. in Ireland who listened to your talk that you gave at Kent State and has read a lot about you. And she says that you've made a big difference in her family. Her mother lost her brother from addiction, and understanding addiction as a brain disease rather than a moral weakness has brought a lot of healing for them. And also there's Kathy O. in Illinois who says thank you because she believes that you're saving lives by helping people understand the physical mechanics of addiction. So you're quite popular in our community. and so thank you for agreeing to do this. It means a lot to us.
Sure. Happy to do it.
I think that because, I represent an atheist and agnostic perspective in Alcoholics Anonymous, and I think a lot of us really value science and understanding, and I think that's why this is so valuable to us to have this. And I thought that I would start, Dr. Labor, by asking you about addiction medicine, that you practice addiction medicine, and I was hoping that perhaps you could tell us a little bit about what addiction medicine is and what you do as a doctor who practices addiction medicine.
Sure. There's two pathways to being an addictionologist, really. You can board certify in psychiatry and then do additional training in addiction psychiatry. And then the other option would be for you to do your residency in some other primary care field of medicine, like internal medicine or family practice or whatever, and then do a fellowship in addiction medicine. So really, both of those pathways could lend to the same sort of career. But what I do essentially is medical stabilization, so detox.
Okay.
Detox from opiates, benzodiazepines, alcohol, barbiturates. Those are the dangerous things to come off of. So I do that inpatient. I also do some outpatient detox for opiates. I would never do outpatient detox for alcohol or benz. I do outpatient medication-assisted treatment, so buprenorphine, Vivitrol, Campril, Antabuse, methadone. I also work at a residential facility, so an inpatient facility, and my role there is really in more of a family medicine type role. I do histories and physicals and I do acute visits, but it's with an addiction perspective. So when the patients are complaining about specific, pain syndromes or anxiety, when they come to see me, I am approaching them from the standpoint that chemicals are not really necessarily the answer, and we need to look at other options. And because your addiction, really wants you to use something and is driving sort of this focus, and so that's really what I do in that role. And then what else do I do? Consultations, services. So if somebody's admitted to a medical hospital for, say, like a heart attack or a stroke or pancreatitis or something, and they also drink or use substances daily, I would be consulted to either detox them there or to talk with them about treatment options and their willingness to participate in treatment. Okay. Right now, there's a good portion of social work sort of built into the job, which is a little overwhelming at times. Sure. But, people are looking for referrals and things like that. So, that's really what I do.
Okay. And, we hear all the time that addiction is a disease. And in your talk at Kent State, you mentioned that it's important that we understand why it's a disease. And I was wondering if maybe you could touch on that here about, what makes addiction a disease?
Well, it's a disease because it meets the criteria for a medical model of disease. And so I always explain that for something to sort of qualify as a disease, it has to fit into the medical model, the disease model, which says there's an organ, there's a failure or defect in that organ, and then there are symptoms as a result of that defect. And so addiction falls into that category, just like cancer and diabetes and a broken leg and any other disease that we actually call a disease.
And in this case, the organ that's affected is the brain.
Correct.
And in your presentation that I really enjoyed, by the way, was you were talking about the neurobiology of addiction, which I thought you did a really great job with that because it's a pretty complex subject. And as a layperson, I thought that I could follow it. But I was wondering if maybe you might want to talk a little bit about that. Can you kind of explain what is happening to our brain when we become addicted?
I can try without my PowerPoint. So there's the part of the brain, the cortex, the frontal cortex, which is kind of located on the outside and the front of the brain, and that is sort of our conscious part of the brain, and that's where our coping skills and stress relief and ability to communicate and thoughts and feelings and willpower and choice and all of those conscious things occur in the cortex. And then there's the midbrain, which is a primitive part of the brain that's completely subconscious, and that part of the brain is responsible for our survival. And that part of the brain essentially has three main functions and in a normal person, and that is to nourish the body with nutrients and water, to kill off or run away from predators that are a threat or any kind of threat, and to procreate for perpetuation of the species. And what happens is, for example, when a baby is born, we feed the baby almost right away because the nutrients in food or breast milk or formula actually trigger the reward system in the midbrain, and they activate it so that the midbrain learns, okay, this is necessary for survival. And so what happens in addiction with repeated use of substances is that reward system gets triggered so much that it becomes dysfunctional.
Gotcha.
And so all substances of abuse, all drugs and alcohol that people abuse, release large amounts of the neurotransmitter dopamine, which is our pleasure chemical, and high levels of dopamine repeatedly exposed to the midbrain cause it to actually change in its conformation so that the threshold for pleasure changes.
Right.
And so people need more dopamine to feel the same amount of joy and pleasure that they previously had. So once that happens, it's really only the substances that will make that person feel normal and comfortable and comforted and, happy in any way. And so they repeatedly will seek that out because the midbrain believes, incorrectly, of course, but it believes that the dopamine in that high of a level is what's necessary for survival.
Right.
And so that's what the disease state is. It's this broken midbrain. And further, like beyond that, once that starts to happen, every time the midbrain is activated in a craving, every time the midbrain is like, oh, I need more dopamine so I feel normal, the frontal cortex shuts down. It gets quiet. It decreases in activity. And so that means the parts of the brain where you value your family, where you value your job, where your morals and ethics are, that part of the brain is repeatedly getting sort of shut down.
Right.
And even though the brain is not a muscle, if you think of it like a muscle, if you don't use it, you lose it.
Right.
And so those coping skills and that ability to deal with high-level stress sort of get atrophied. They go away, and you need a substance to help you get through any sort of situation.
Right. And you also mentioned that that genetics or genes also play a role in this. And I was kind of wondering, so like almost everybody has a gene for addiction, from what I understand. And it takes and there's many different genes for addiction, and that gene has to be activated, and it's different for every person. So like, does that gene have to be activated before you have the problem with the dopamine? How are those related?
once the gene is activated, then the problem with dopamine occurs.
Okay.
So you can use substances and get high levels of dopamine over and over and over, but your brain is not going to change to need more dopamine until that gene has been activated.
Gotcha. Okay. That makes sense. I understand that now. Okay. Well, and that gets us into the trap of, because you were talking about the role that stress plays in the whole addiction cycle. Because of course we become addicted, we have problems in our lives, it brings on stress, which makes us want to use. Could you go into a little bit about what happens with stress and what role stress plays in our addiction?
Well, stress, chronic and severe stress, which generally would be defined more like a trauma, of some sort. But trauma obviously could be something as simple as feeling neglected, loss of loved ones, where the ability to cope with that for whatever reason has been disrupted. So that's sort of trauma. So that's chronic severe stress. When that happens, when someone experiences long-term or chronic severe stress, what happens is the body releases something called corticotropin releasing factor, CRF are the initials. And when you have high levels of CRF circulating in the system, that chemical actually causes the same sort of change in the midbrain as repeated drug use. Okay. So if you have chronic severe stress and it predisposes you to need more dopamine to feel normal or okay, and then you use a substance and realize, oh wow, this actually makes me feel normal or okay, then you will continue to seek out those chemicals because you know that they're making you feel better. Mm-hmm. And then, of course, on the flip side is if you become addicted first by repeated use of substances, then you start to experience sort of trauma from your addiction. I mean, addiction can be a very traumatic experience just in terms of the lying and the manipulating and the living a double life and the inability to function in society appropriately. Those are very stressful things. And so you sort of activate that chronic severe stress state, which then further causes the problem in the midbrain. So they just compound on each other. So addiction causes stress, which will then further the addiction. Stress can lead to addiction, which will then lead to more stress. And so it's a vicious cycle.
Mm-hmm. And the treatment for this is to strengthen the frontal cortex. And so the listeners to this podcast, we're involved in 12-step program. And so do you see that as a useful way to strengthen our frontal cortex to somehow, recover from this?
The 12 steps to me is, I call it spiritual growth for dummies. Mm-hmm. And spiritual growth is the fastest and most effective way to strengthen the cortex. Yep. And so I promote the 12 steps always. Yeah. Simply because if you do them in the order that they are written, then you rewire the spiritual part of the brain in such a way that it is able to overpower an active midbrain or a diseased midbrain. Right. And so the 12 steps is, I always tell people, statistically 100% effective for recovery. Yeah. Provided that you take 100% of the suggestions.
Right. Yeah. I think there's I think that most of us recognize that we need to change. We need some sort of a process to follow. And it helps us to have that process, but also to have each other's support. But one thing that's on my mind, Dr. Labor, that I want to ask you about is relapse. Because I've been sober now for 30 years and going on 30 years, and unfortunately, I've seen a lot of people relapse. And even as an alcoholic, it's sometimes hard to wrap my head around why this happens. Someone that might have been sober for a good long time will relapse. Do you have any understanding of this? Why is this happening, and what could be done to prevent it?
Well, I mean, there are three reasons humans relapse, right? So, one is exposure to high-level dopamine. So, being exposed to drugs and alcohol, even if they're, medically necessary. Right. Or, a glass of wine or champagne at a wedding, or a beer at a barbecue, or smoking pot in the basement with your friends or something. Those release high-level dopamine, and so when you expose your brain to that, you reactivate the addiction process, regardless of how long you've been clean. And The second thing that causes relapse is stress, which we talked about already. And then the third thing would be people, places, and things. So, because the brain is able to remember events that surround getting high-level dopamine. So, if you always got high with person A, then your brain associates person A with getting dopamine. So running into that person, hanging out with that person is going to trigger the addiction to sort of wake up. And when you talk about addiction, the way it was explained to me and the way that I pass it on is if you're walking through the woods and you create a footpath and then you keep walking on that same path, eventually it's worn down and now it's a little bit wider and it keeps getting, now it's a one-lane dirt road that a car can go on, and now it's a one-lane paved road, and now it's a two-lane paved road. And by the time you reach sort of the peak of your addiction, it's a 16-lane highway with traffic in both directions. And when you stop using and you start working a recovery program, you basically hang up some yellow police tape across that highway.
Yeah.
And so when you get exposed to dopamine, when you get exposed to chronic severe stress, or when you get exposed to people, places, and things, you're basically pulling down that police tape. So what has to happen in order to prevent the actual relapse would be to start working out that cortex.
Yeah.
So you have to refocus your efforts on strengthening that cortex. And so that's when, I tell people, you run into an old using buddy at the Circle K when you're buying milk. If you're going to 2 or 3 meetings per week, you need to bump it up for a little while.
Yep.
If you get a prescription for a pain medicine after a knee surgery, if you go to 3 meetings a week, you should be going to 5 or 6 meetings a week. Yep. And so you need to increase those supports. You need to sort of practice the coping skills even more so during those times of risk. Because I certainly have seen that as well. And I've seen people, with 40 years of sobriety, work in a program who wind up on the detox unit because they've relapsed. And I say, what happened? And they say, inevitably, 100% of the time in my experience, they say, I stopped going to meetings.
Yeah.
And I say, why? And they say, because I had 40 years sober. I figured I was good. And I say, how long? How long were you able to go without going to meetings before you relapsed? And generally, it's less than a year.
God, that's incredible. It's like constant vigilance. It takes constant vigilance to do this. I find myself when I'm going to meetings and I'm connected with people, I'm happy and I enjoy it, but I can fall out of the habit. And it's kind of a gradual thing. Like, I won't go to a meeting today. I won't go to a meeting tomorrow, whatever. And I guess that could put me on thin ice, if something happens in my life that causes some stress.
Sure. Well, when you think about once you have the disease is always your default.
Yeah.
So if you're not actively taking steps toward being sober, being clean, then you're going to be sliding backwards towards relapse. Now, it may take some time before that relapse occurs, but ultimately that's always going to be the default, is to slide backwards. And that's it's normal. Life has ups and downs. You're going periods where maybe you're not as active in the program as other times, but if you stay consistent and you stay in contact with those people and you stay aware of your defects and what's going on in your life, and when you can recognize, when you have that awareness, like I see myself sliding, and you force yourself to sort of get back into it. It's like anything else. It's like if you want to build muscle, if you want to create big biceps, you can do it and how you can go to the gym 8 hours a day, build those muscles up. But if you stop going even for an hour a day, eventually those muscles are going to go away.
Yeah.
So to maintain them, you have to continue to do work every day.
Yeah, it's probably another good reason to have somebody close, that you can stay in touch with, maybe that might notice that if you're starting not to show up at meetings or whatever, to just kind of point it out and get you on track. Because it's scary, because once a person relapses, it's not always a guarantee that they're going to make it back. And that's just that's heartbreaking when you know somebody who's been happy and sober and then they go through the relapse. So I guess another good thing though about it, Dr. Labor, it's in a way, it's good for me to see that, because it kind of reminds me of how serious this thing is, So that's another good reason, I guess.
And if you're constantly there, if you're constantly around people in different phases of recovery, you can learn from their mistakes. That's the gift of being sober, is that you don't have to do everything everyone else did just to see that it's going to fail for you too.
No, you don't. Yeah, you get to see the good and the bad. You get to see the people get their lives together and get their families together. and you see the bad, you see it all. So I guess that I mean, there's a lot of value in that. So, it's something that's something to consider. I was going to ask you about, the role of medication in treating addiction. I mean, one topic that we talk about sometimes among our members is naltrexone and the use of naltrexone. What do you think of that? What are your opinions about medication and treating addiction?
I think that relying on a chemical to treat chemical dependency is dangerous.
Yeah.
And I think that if you're using a medication as your primary source of trying to stay clean and sober, then you're going to fail.
Okay.
However, I do think that using medication to sort of quiet down that midbrain, so that you can focus on strengthening that cortex and strengthening that, program of recovery. I think it can be really beneficial.
Yeah.
I think the biggest problem I run into, though, is that all addicts want something quick and simple. And so when they hear there's a medication, a chemical available that could help them, there's a huge drive to sort of rely on that chemical, and then they don't do the work. Right. And then they relapse and they say, oh, this medication doesn't work. And I always say, well, the medication was working fine. You weren't working. You weren't doing anything other than taking a medication or a chemical, which is what you were doing to get you in this situation in the first place.
Right. Right. And you also pointed out in your talk that not all medications work, because addiction is not specific to any particular drug, but medications are. So I might take a medication that will be great for helping reduce my alcohol craving, but then I might start smoking pot, or I might start doing some other drug for that medication might not work on either. So.
Correct, because that medication is working in the midbrain, but it's not doing anything for that cortex. And if you don't strengthen your coping skills and your stress relief and your social support, then your brain's still going to need higher than normal levels of dopamine.
Yep.
So you're going to seek it out in another form. And I see that all the time. And I see it in, people, an alcoholic, for example, that comes to treatment and says, I don't ever use other drugs. I hate drugs. I never liked them. I never used anything. And then they get on, say, Vivitrol for anti-cravings, and maybe they go to AA meetings and they're able to stay abstinent from the alcohol. And then the next time I see them, they're taking Xanax, or they're using an opiate pain pill or something. And it's because that brain will justify and make an excuse and find a way to get that dopamine as much as it possibly can.
Yeah. And also, you talked about addiction as being, it's really not a drug addiction. It's a dopamine problem is what it is. So there's also certain behaviors that maybe we need to watch out for, because there are process addictions you talk about, like gambling and things like that also have an impact on our dopamine, though not to the extent, I guess, of these drugs that we use. So is that something that, we probably should also watch out for, is just certain behaviors that might elicit, certain reactions in our brains?
Always. Process addictions generally release higher than normal levels of dopamine, not quite as high as substances. So what we often see happen is, as that threshold for pleasure starts to head back down to normal, someone will discover that, hey, gambling or having sex or watching pornography or shopping or eating makes me feel normal and okay. And so that threshold sort of gets stuck in that place. And so they're still not able to get real joy or happiness from normal activities, but they're not necessarily needing the drug. And so those behaviors become the new addiction.
Right.
And what'll happen is, of course, if you need to gamble just to feel normal on a Tuesday, then when something very stressful happens, your brain again is going to say, we still need more dopamine, and you're going to wind up relapsing back on the substance. That you were originally using. And so those can, and I know, the process addictions is sort of a whole other topic, because obviously, gambling you can live without, but certainly eating you've got to eat, and having sex, or having at least sexual relations, is sometimes necessary in life. And so the treatment for those is exactly the same. I recommend a 12-step program for those, but instead of completely remaining abstinent, you sort of define a boundary around that behavior.
Right.
So people say to me, oh, when I exercise, I never want to use, I feel good. And I always say, well, how much are you exercising? Because if you're going to the gym for an hour a day and that's it, fine, that's great. I'm glad that that's helpful. But if you're working out, 3 and 4 times a day for 5 and 6 hours a day, that's not healthy.
Yeah, right. I've known people, I'm not one of those, but I've known people who do that. So, and I guess maybe a good place to kind of finish up, we're coming up on 30 minutes. Public policy. Are you very involved with, advocating for a particular type of public policy for dealing with addiction in society? And do you think that we're kind of on the wrong track now or right track? What do you think about all that?
Well, I mean, I'm super busy with clinical care.
Yeah.
And so I don't take a huge active role in the politics of it.
Yeah.
Other than, my flapping my lips and giving my opinions to people. But I mean, my opinion on the subject matter is simply that the problem is always the same as the problem with anything else, and that's the bottom line, and it comes down to dollars. And addiction doesn't bring any money to anybody. So treating it isn't making anybody any money.
Right.
And, people have health insurance and they won't cover the treatments that are available. And yet people are up in arms crying about why don't we have more treatment centers available? Well, because you don't have anybody that's willing to work for free. That's why. And so, do I think that the government needs to allocate all these billions of dollars towards, development of treatment programs? No, I think the government needs to advocate for the health insurance companies that already have the money to use it for what it was intended for, to treat people.
Yeah.
And I think if you didn't have those barriers, we'd be able to open and staff facilities so that we could treat the problem. And I think that, and that takes the burden off the rest of society, because there are certainly a lot of people out there that don't believe it's a disease and don't think their tax dollars should have to go to treat these degenerates and they're entitled to their opinions. But from my standpoint, there's no need for that, because these people have insurance, and even if it's state, Medicaid or Medicare or some other, government funded insurance, it's still their health insurance. So why shouldn't it treat their health? If we're calling it a disease, let's treat it like a disease. So I think that, really is where it needs to start, because it becomes impossible. I can have pipe dreams all day about opening amazing facilities with all of these options and, how to properly do it. But if I have no way to pay for it, if I have no way to pay myself and my mortgage and my staff and my counselors and, then I couldn't possibly keep a facility like that open. Yeah. And so, and the ones that are out there that are thriving are the ones that take, that have patients who come from a different background that they can afford to pay out of pocket for these kinds of treatments. My patients certainly can't.
Yeah. And, I just read a book about the kind of the history of treating alcoholism. And it's like we've gone through these periods of time where we would treat it as a disease with some compassion, but then we'd go through these eras like during Prohibition where we focus on the substance itself and punishment and that sort of thing. And it seems like anytime we go that way, it never works. I don't know what the answer is, but I do think it's just important that I guess society as a whole understand it as a disease, and I mean really understand it from the way you describe it as a brain disease, as an organ that's being affected, and that's why we act so screwy. Is our brain is messed up. So anyway, I guess one thing I guess I would conclude with is: do you see anything promising? Is there any new research? Is there anything new in science that you're aware of that in the field of addiction that looks promising?
I can't honestly say that I've seen. I know that Western medicine really likes to focus on pharmaceuticals. And so that's where the dollars and focus has been, on creating new medications. There was talk of a vaccine at one point. I don't know how that would. I don't really know, other than sort of teaching people to sort of cope with life, before they ever get access to a substance. I'm not really sure, but no, I haven't really, but I also, I mean, admittedly, I'm not like research reader. Like
right.
If I have some free time, I kind of want to read something like, mindless.
Well, that makes sense. You're dealing with addictions and addicts all day long. So probably you do want
and I try to never, ever take my work home with me. So
yeah.
the less I have to do and, read at home, the better for me. But if something comes across my desk or someone sends me an email with an article, I'll generally read that, but I haven't heard anything groundbreaking.
Well, thank you again for doing this. I appreciate it. I've been to Akron before, by the way. It's a beautiful city. It's a great part of the country. Great place to live, I would think. But
well, especially if you're in AA.
Yeah, that's what I went up there for. Actually, I was with a group of people, and we did the whole tour, the whole AA history tour, and it was fun. It was a lot of fun to see that, and I do appreciate the history of AA. It's when you think about it, what this fellowship has been able to do, and all the individual AA members, and the difference that we've been able to make over time. A lot of the progress that has been made in addiction treatment has come from people who got sober in AA, quite frankly. And a lot of these other groups that have spun off, that are helping out people with other addictions, all spun off from AA. So it's something I'm kind of proud of, although I know that's not a really good word in AA, but I'm kind of proud of what we've been able to do. But, thank you again. Well, thank you very much. You have a good day.
All right.
Bye-bye.
You too.
Well, that's it for another episode of AA Beyond Belief, the podcast. Thank you very much for listening. I appreciate your support. If you have any ideas for a podcast, or if you'd like to be a guest on a future podcast, please send me an email. You can get in touch with me at john@aabeyondbelief.org. That's John,